Welcome to the Noted Pharmacist, your trusted platform for pharmacy and medical education. In today's segment of our Pharmacology lecture series, we are going to explore adrenoceptor blockers, a critical class of drugs for managing various clinical conditions. Previously, we discussed sympathomimetics and their clinical applications. Be sure to check out the separate quiz video on adrenoceptor blockers, featuring 10 MCQ questions with answers and explanations. The link to the video is provided in the description. The following are the learning objectives of this video. We are going to review the classification of adrenoceptor blockers and their receptor selectivity. We are also going to look at mechanisms of action underlying their clinical effects in various systems. We are also going to identify the pharmacokinetics influencing use and safety considerations. Explore clinical indications and conditions treated by these drugs. Evaluate adverse effects, drug interactions, and contraindications. Discover newer agents and their advanced therapeutic benefits. Now, let's delve into the introduction of adrenoceptor blockers. Adrenoceptor blockers, also known as adrenergic antagonists, are drugs that inhibit the actions of the sympathetic nervous system by blocking adrenergic receptors. These agents can target either alpha or beta receptors, leading to effects like vasodilation, decreased heart rate, and reduced smooth muscle tone. Adrenoceptor blockers play a pivotal role in therapeutics, addressing conditions such as hypertension, angina, BPH, and heart failure. Their ability to selectively block adrenergic activity makes them essential in cardiovascular medicine, endocrinology, and urology. We will look at their clinical application in greater detail in the coming sections. Let's briefly look at classification, starting with key members in this class of drugs. Some key examples of adrenoceptor blockers include propranolol, atenolol, labetalol, carvedilol, phentolamine, phenoxybenzamine, tamsulosin, and doxazosin. Each drug has specific therapeutic roles. Adrenoceptor blockers are classified into alpha blockers, beta blockers, and mixed alpha-beta blockers. Alpha blockers are drugs targeting alpha-adrenergic receptors, divided into alpha-1 and alpha-2 subtypes. Alpha-1 blockers, such as tamsulosin, primarily relax smooth muscles in the prostate and bladder neck, aiding in conditions like BPH. In contrast, alpha-2 blockers, like yohimbine, increase norepinephrine release, enhancing sympathetic tone and clinical use in erectile dysfunction. Beta blockers are pharmacological agents that inhibit beta-adrenergic receptors, classified into non-selective and cardioselective types. Non-selective beta blockers, like propranolol, target both beta-1 and beta-2 receptors, while cardioselective agents, like atenolol, primarily block beta-1 receptors. Mixed alpha and beta blockers, such as labetalol and carvedilol, exert dual actions by blocking alpha-1 receptors to induce vasodilation and beta receptors to decrease heart rate and myocardial contractility. This combined mechanism is particularly effective in managing hypertension and heart failure, providing enhanced hemodynamic stability and reducing cardiovascular strain. The table below categorizes adrenoceptor blockers into their subclasses for clarity. Alpha-1 blockers like tamsulosin and prazosin relax smooth muscles for BPH and hypertension treatment. Alpha-2 blockers such as yohimbine enhance sympathetic tone, aiding in erectile dysfunction. Beta blockers are divided into non-selective agents like propranolol, cardioselective agents like atenolol, and mixed blockers like carvedilol. Mixed blockers uniquely provide vasodilation benefits, making them effective in managing hypertension and heart failure. Mechanism of action. Adrenoceptor blockers inhibit endogenous catecholamines, such as adrenaline and noradrenaline, at adrenergic receptors. This action is critical for their therapeutic effects in various conditions. Alpha blockers prevent catecholamine-induced vasoconstriction by inhibiting alpha-1 adrenergic receptors. Drugs like prazosin and terazosin cause vasodilation, reducing vascular resistance and blood pressure. Alpha-2 antagonists like yohimbine enhance norepinephrine release by blocking presynaptic receptors. Beta blockers reduce sympathetic stimulation by inhibiting beta-adrenergic receptors. Cardioselective beta blockers, like atenolol, selectively block beta-1 receptors, decreasing heart rate and myocardial contractility. Non-selective beta blockers, like propranolol, block both beta-1 and beta-2 receptors, potentially causing bronchoconstriction. Mixed alpha-beta blockers, such as carvedilol and labetalol, provide dual-action effects. They lower heart rate and myocardial oxygen demand through beta blockade, while their alpha-blocking properties reduce vascular resistance, making them effective in conditions like heart failure and hypertensive crises. Now, let's explore the pharmacokinetics of adrenoceptor blockers, looking at how these drugs are absorbed, distributed, metabolized, and excreted, which informs their clinical use and dosing considerations. Adrenoceptor blockers like propranolol and atenolol differ in bioavailability and metabolism. Propranolol has 30 to 35% bioavailability due to extensive first-pass metabolism and high lipid solubility. In contrast, atenolol, with 50 to 60% bioavailability, undergoes minimal first-pass metabolism but has low lipid solubility, influencing its therapeutic applications. Adrenoceptor blockers undergo diverse metabolic pathways, crucially influencing drug pharmacokinetics and efficacy. Lipophilic beta blockers like propranolol are metabolized hepatically, subject to first-pass effects, while hydrophilic agents like atenolol are excreted renally, minimizing hepatic involvement. Selective alpha blockers, such as prazosin, rely on hepatic biotransformation, underscoring metabolism's pivotal role in clinical decision-making. Adrenoceptor blockers demonstrate varying excretion properties influencing their clinical utility. Esmolol, a short-acting beta-1 selective blocker, is rapidly hydrolyzed in plasma, requiring continuous infusion for sustained action. Conversely, nebivolol, a long-acting beta-1 blocker with vasodilatory effects, permits once-daily dosing due to its prolonged half-life and hepatic metabolism. Let's review the indications and clinical uses of adrenoceptor blockers. The advent of beta blockers revolutionized cardiovascular medicine, with propranolol becoming the first approved agent for managing angina pectoris. By decreasing myocardial oxygen demand through competitive inhibition of beta-adrenergic receptors, propranolol not only alleviates angina symptoms but also reduces heart rate, making it a foundational therapy for chronic stable angina. Alpha blockers, including prazosin and the uroselective tamsulosin, are key in managing benign prostatic hyperplasia, BPH, by targeting alpha-1 adrenergic receptors in the prostate and bladder neck. Tamsulosin's specificity minimizes systemic effects, enhancing urinary flow while preserving hemodynamic stability, making it a preferred choice in patients with coexisting hypertension or cardiovascular risks. Beta blockers, such as metoprolol, play a pivotal role in managing heart failure and post-myocardial infarction, MI. By attenuating sympathetic overstimulation, they reduce myocardial oxygen demand, enhance left ventricular function, improve survival rates, and significantly lower the risk of recurrent cardiac events and hospitalizations. Non-selective beta blockers, such as propranolol, are widely utilized not only for cardiovascular indications but also in managing neurological conditions like migraine prophylaxis by modulating vascular tone and reducing neuronal excitability. Additionally, they are effective in essential tremor by attenuating involuntary oscillatory muscle activity through peripheral beta receptor blockade. Mixed alpha-beta blockers, such as labetalol, are pivotal in managing hypertensive emergencies and gestational hypertension due to their dual action of reducing blood pressure while preserving organ perfusion. These agents act quickly by blocking both alpha-1 and beta-adrenergic receptors, ensuring vascular relaxation and decreased cardiac output for safe and effective control. Let's look at safety considerations for this class of drugs. Adrenoceptor blockers are widely utilized in clinical settings for conditions like hypertension, angina, and arrhythmias. Despite their therapeutic benefits, understanding their safety profile is crucial to mitigate risks and ensure optimal patient outcomes. Common adverse effects. Adrenoceptor blockers often cause fatigue, dizziness, bradycardia, and hypotension, which may limit their tolerability. Serious adverse effects include bronchospasm, particularly with non-selective beta blockers like propranolol, heart block in predisposed patients, exacerbation of heart failure in certain cases, and severe hypoglycemia masking in diabetic patients. Fatigue and dizziness are frequently reported, but bronchospasm is life-threatening in asthmatic individuals. CNS side effects. CNS side effects associated with adrenoceptor blockers include depression, vivid dreams, and insomnia, particularly with lipophilic drugs like propranolol. These effects, while not life-threatening, can significantly impact adherence and necessitate careful consideration of alternative therapies. Key warnings for adrenoceptor blockers include cautious use in patients with asthma due to bronchospasm risk, avoidance in decompensated heart failure, and careful monitoring in diabetes where they may mask hypoglycemic symptoms. For example, propranolol should be avoided in asthmatics, while carvedilol is safer in heart failure management. Beta blockers can cause sexual dysfunction. These precautions ensure appropriate use and enhance therapeutic safety. Absolute contraindications for adrenoceptor blockers include asthma for non-selective beta blockers, severe bradycardia, cardiogenic shock, and second or third degree heart block without a pacemaker. Propranolol, for instance, is contraindicated in asthma, while atenolol and bisoprolol require caution in severe bradycardia. Recognizing these conditions is pivotal to prevent adverse outcomes. Drug interactions. Adrenoceptor blockers exhibit significant drug interactions that can amplify adverse effects or diminish therapeutic outcomes. Non-selective beta blockers combined with calcium channel blockers like verapamil or diltiazem pose a heightened risk of bradycardia or heart block. Additionally, NSAIDs may impair beta blockers' antihypertensive efficacy, while abrupt clonidine withdrawal alongside these agents can provoke severe rebound hypertension. Adrenoceptor blockers like atenolol and sotalol require cautious use in renal impairment due to their renal clearance. Hydrophilic agents like atenolol may accumulate, while sotalol's elimination can increase QT prolongation risks. Non-selective beta blockers, such as labetalol, are safer choices for managing hypertension in pregnancy despite risks like fetal growth restriction. Atenolol is generally avoided due to links with fetal bradycardia, while metoprolol offers a safer alternative. Adrenoceptor blockers, such as propranolol, are generally considered safe during lactation, with minimal infant exposure reported. Conversely, atenolol, due to its lower plasma protein binding and higher renal excretion, poses a risk of significant neonatal exposure and adverse effects, warranting its avoidance in breastfeeding mothers. Let's look at newer agents in this class. The development of newer adrenoceptor blockers has improved their selectivity and safety profile. A good example is nebivolol. Nebivolol is a highly selective beta-1 adrenoceptor antagonist, and it also exhibits beta-3 agonist properties. This dual action not only lowers blood pressure but also induces vasodilation through nitric oxide release, enhancing its efficacy in treating hypertension. Another newer agent recently developed is silodosin, which is a highly selective alpha-1A blocker for benign prostatic hyperplasia. This medication selectively targets the alpha-1A adrenoceptor subtype, primarily found in the prostate. Its selectivity reduces the risk of side effects such as orthostatic hypotension, making it a preferred choice for treating benign prostatic hyperplasia, BPH. Now that we've explored adrenoceptor blockers, let's take a moment to recap. We've covered the classification and receptor selectivity of adrenoceptor blockers, their mechanisms of action and effects on various organ systems, clinical uses, including cardiovascular and urological indications, pharmacokinetics influencing drug choice and dosing considerations, common and serious adverse effects with key safety precautions, emerging agents like nebivolol and silodosin with enhanced therapeutic benefits. In conclusion, adrenoceptor blockers are vital in the management of cardiovascular, urological, and endocrine conditions. Their broad therapeutic applications underscore their importance in clinical practice. Be sure to check out our next video on drugs used in hypertension, where we'll explore their mechanisms, clinical applications, and relevance in pharmacology. This will provide a comprehensive understanding of antihypertensive therapy. For further reading, consider resources such as Katzung and Trevor Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. Thanks for watching. If you found this video helpful, don't forget to give it a thumbs up and share it with others. Subscribe to this channel and hit the notification bell so you never miss an update in the series that we are doing. For more learning resources, check the description below. See you in the next video.